I am Meaghan Evans, and this is Kristen Grovue, and we work at the Pelvic Floor Clinic with Grace and Dr. Birch. We are the physiotherapy team, and we chose today to speak about, are you strong enough to lift your bladder? Common myths and misconceptions about pelvic floor and core muscle training. Very long, but it's a topic that we like to speak about, partly because when patients come in, their perception of what may be happening with incontinence or pelvic organ prolapse around their muscles and what they can do to help. And also, those of us working with women, how to properly help them with pelvic floor and understanding pelvic floor and core muscle training. Oh, we're going to present it. There's 5 myths that we've kind of compiled, and we'll present those, and then we're going to intertwine. Kristen will be presenting clinical scenarios, so hopefully you can apply it clinically when you go back to your practices. Disclosures, conflict of interest, we don't have any. We figured, though, as Grace said, Kristen and I first worked together at an orthopedic clinic 20 years ago, and then we came to work together 9 years ago at the pelvic floor clinic. So our disclosure is maybe that we are pelvic health geeks. We love it. We love to speak about pelvic floor and core and getting women back to health around their pelvic floor. So, myth number 1, incontinence is caused by weak pelvic floor muscles. So often I find women will, can you hear me? Women will come in and they'll be concerned, with symptoms, pelvic prolapse, urinary or fecal incontinence, and they say, oh, I just must be weak. I must be weak, and I just need to strengthen and work harder, and then I won't have problems. And I imagine that in there, I try and get women to describe what they think is happening, because it's very important what their perception is. We can tell them the anatomy, but you kind of want to get a sense of what are they picturing, because that's the story that they are telling themselves. So I imagine they think their pelvic floors are hanging down like these hammocks, and if they could just pull everything up, then symptoms would be gone. And so the flip side of that, myth number 2, which is strong pelvic floor muscles will cure my incontinence. And yeah, that would be simple if it were so, but strength is only one component of muscular function, not just in pelvic floor muscles, but any muscle in the body. If we're talking about muscular function, strength is not a standalone component. So just the thought that, well, I'll just strengthen and all my problems will be solved. If I thought that way, I would just go to the gym and do my bicep curls and walk out and go play tennis at Wimbledon. Then I'd be a great tennis player if all I needed was bicep strength, right? And I mean, that's an example that seems a bit silly, but in the pelvic floor, the way we use the language is just strengthen it up and it should all be good. And again, strength alone does not equal function, and strength alone does not equal continence. So with muscular function, you need strength, yes, but you also need endurance. You need the ability to coordinate in the pelvic floor. To contract is as important as being able to relax that muscle. Just squeezing all the time does not make a muscle functional. You have to have the capacity to go through range of motion and relax. So the point is that it is a little more involved than just saying, well, we'll strengthen you up, and there you go. You'll be good for your golf game and your lifting heavy boxes, let's say. So I just want to make sure that today we are speaking about pelvic floor muscle training and what I call the modifiable components of continence. So we are aware that there are some non-modifiable, as Dr. Birch was talking about anatomy. There's fascial, ligamentous, laxity or tears. There's urethral coaptation. There are other components that aren't as modifiable around continence and prolapse, but we are mainly speaking to the neuromuscular components that we can modify with training today. And then the third myth is Kegels can be done anytime, anywhere. We're all busy, and I just need to strengthen up down there, and why don't I do it during red lights and grocery lines. And partly the reason we put this in as a myth is the term Kegels, if most of you are probably aware, I think it was Arnold Kegel, was a gynecologist in the 1950s who had a very rigorous pelvic floor muscle training program for postpartum women and stress urinary incontinence. But over the years, the term Kegel, maybe kind of like Heimlich, it became associated with his name, and it kind of morphed into this just squeeze, any number of times. It's been all over the map what I've heard women have been told. For a while there was a trend to have women stopping urine flow as practicing the exercise until they realized, oops, that's maybe causing some retention in some women that are practicing holding while they're trying to avoid. So it's gone through many incarnations, and Kegel seems to imply that it's like one size fits all. This is what you do for pelvic floor dysfunction, and each woman sort of presents differently. So we use, and hopefully the literature is going that way too, pelvic floor muscle training as a term. I don't usually refer to it as Kegels anymore. And the fact that it can be done anytime, anywhere. And again, we're all busy. I don't want one more thing to have to do in my day where I have to focus on that and take time out. But if you are looking at motor learning, especially around the pelvic floor, which is a difficult area to feel, see, get feedback, if you're doing it mindlessly, and also, we know from research that 50 to 70% of women on verbal instruction are not contracting and relaxing their pelvic floor levator ani muscles correctly. Then if they're just doing squeezing, like I was told, I'm in the grocery line, you're not going to get good transfer of motor learning that way. In the initial stages of neuromuscular retraining, you need to be concentrating on what you're doing. So when we do prescribe pelvic floor muscle exercises, it will be at times where they can at least focus. In the beginning stages, you can progress to maybe do it when you're more doing other tasks, but really just trying to say, well, do it when you're doing other things isn't really going to be effective. They're going to say, and a lot of them come in and say, well, I tried Kegels and they didn't work. And that's usually been their experience with it. So, so we have a clinical example of how to progress through not just, a basic, but how to progress through to muscle function with pelvic floor muscle retraining.
Okay, so first of all, I think before we talk about how to progress the exercises, I want to mention muscle tone. And the word tone has floated around the room a few times today, but I want to make sure that we all understand what that means. So you can have a hypotonic muscle or a hypertonic muscle or a muscle that has normal tone. So to give you an idea of what normal tone would feel like, I want you to all just take your index and your thumb and just squeeze the thumb pad on your opposite hand. So it's it's firm, but it's got some squish to it, right? So that would be a good example of normal muscle tone. If it was really soft and there was just not much resistance as you did that, that would be more hypotonic. But if you try to squeeze your thumb and index together now and just pinch gently, and now feel that muscle belly, you can feel how much firmer it becomes. And that would be an example of what a hypertonic muscle feels like. So when you're assessing the pelvic floor muscles, you want to get a sense of what their tone is like, because that will dictate how you're going to actually address and treat this patient, okay? When you are palpating these muscles, it's also important not to just palpate at the introitus, at the vaginal opening, but get right down onto the levators, palpate and compare side to side. And you can also assess the obturator internus vaginally by going more laterally on the side walls of the pelvis and just have them gently resist their hip into external rotation, and you'll feel that muscle pop into your fingertips quite nicely, okay? So if somebody is hypotonic, We would grade them. We'd give them a grade from 0 to 5. So 0, I always say, well, you know, you're here and your pelvic floor's somewhere in the Caribbean. And a grade 5 would be like Olympic level strength, which I hardly ever give anybody because I always think there's got to be that extra little bit of room for improvement. But anyway, so if you evaluate somebody and you place them at, say, a grade 1 or 2, chances are they're going to need to start doing their exercises in a supine position. Not always. Sometimes they actually feel sitting is easier. But usually once they get to about a grade 3 out of 5, that's a level where they can actually start to contract against gravity, okay? So that's when they would be in a more sitting or eventually standing position. So again, as Meaghan was saying, if they're, say, a grade 1 and you're saying, well, practice this, you know, standing while you're waiting for your kids to get out of school or in the grocery line, they're not going to be able to effectively do that contraction. They just don't have the strength yet. So now if they're a 0, if you feel absolutely nothing going on, then we can use things like muscle stimulation. We have real-time ultrasound in our clinic, so you can actually have the patient see their bladder and visualize their pelvic floor. That visual input is a really good way for motor learning to occur. Or we can use some facilitatory techniques using other muscles that function with the pelvic floor. And if we get those guys firing, sometimes you can get a nice overflow of the pelvic floor, so that can start contracting as well. So that one-on-one time with the patient for them to actually establish that motor learning is really critical at that stage. As Meaghan said, when we're teaching the exercises, we'll focus on strength, but we also need to focus on other muscle functions like speed, right? If somebody has stress incontinence and they cough, but it takes them 5 seconds to generate a nice strong contraction, well, who cares, right? The intraabdominal pressure has already hit their bladder and they've leaked. So you have to address speed. You may need to address the endurance, how long they can hold, their range of motion. So they should be able to contract and completely relax that muscle through its full range of motion. We would then take the basic exercises, addressing those muscle components, and progress them into more challenging positions. So we would go from supine to sitting, maybe sitting on an exercise ball, because the ball kind of comes up and meets the perineum. It's a nice way to give them a bit of feedback. Then maybe we'd progress them to standing, or to standing with your legs apart, or a full squat. That gets a lot more challenging, right? And once we can get them into an upright position, then we would start to address the more functional types of exercises. So let's say somebody has stress incontinence every time they jump, or they're playing soccer and they're making those quick directional changes and they leak. We can take that problem, modify it, and turn it into an exercise for them, and then gradually make that exercise more and more challenging until they're actually able to complete the task where they're having their symptoms. So let's say jumping, for example, makes them leak. You could start them, say, maybe on a softer surface, like a rebounder, or on, I always say the guest bedroom bed, not your own bed, but stand and just bounce and get used to feeling your pelvic floor react to that load. Maybe then you could progress it to running on the spot, to starting to jump, and then move towards a dry land situation. You could start with an empty bladder and then progress to a more full bladder. So there's all these little steps that are still kind of creating that problem or creating that exercise that you're having difficulty with, but you're starting it at a level where they actually can have success, okay? So that's the hypotonic patient, which I think is who we classically think of the most, but there's also the hypertonic patient. So this is somebody that we would call a tight pelvic floor or a non-relaxing pelvic floor. These are often your pain patients, so they may have low back pain, pelvic girdle pain, hip pain, dyspareunia, those types of things. And these patients can also present with prolapse, stress incontinence, right? If you don't want to leak, what are you going to do? And if they're like this is functionally weak, right? I would never go to the gym and do my biceps curls like this. Again, you've got to take that muscle for it to be strong and healthy and take that muscle through its full range of motion. So if you just send these people home with the hypotonic patient exercise program, you're likely going to make them worse because you're just tightening up something that's already quite tight. What we need to start with these gals is teach them how to lengthen or relax their pelvic floors. And that can be really challenging for them because they often have a very poor body image in their brain, in their somatosensory cortex, that part of your brain that has that picture of all your body parts. It's a really tough thing for them to figure out. So we'll use lots of visualization with those people, just again to try to create a better picture in their mind's eye. And then as they get better at figuring out how to relax their pelvic floor, then we start to get them to check in randomly throughout their day and go, oh, where is my pelvic floor? Oh yeah, it's up here again. Okay, I have to let it go. So you're trying to get them to create a new normal resting state, a new baseline from which their pelvic floor is functioning from. And at that point, you'll often discover that these patients aren't actually that weak. Their pelvic floors aren't actually that bad. And then you can progress into your regular sort of strength training program.
Okay, so myth number 4, abdominal crunches are a good exercise to strengthen the core. So we put a lot of points in here to address, and some of this comes from, again, some of our patients come in and they've done their research on the internet and they have found out that I need to strengthen my core and my pelvic floor, and this is how I'm going to do it with crunches. So first, understanding, clarifying a bit what is the core. We hear a lot about that. We think it means to have a strong abdominal wall. That will make my core strong. And again, this term strength is bandied around, and what the core is, it's a set of postural muscles. So these are muscles that lie very close into the skeleton, and they include your thoracic, your diaphragm, okay, your breathing used for respiration, but it also has other roles, and one of them is a core muscle. Your pelvic floor levator ani muscles are part of the set of core muscles. Your deepest abdominal muscle layer is called the transversus abdominis, and they lie underneath your rectus and underneath your oblique abdominal muscles, and they act like a corset, like we're both wearing horizontal stripes, not planned, but that is what the transverse abdominals do, is they wrap around the trunk and insert into the deep spinal muscles called the multifidus. And multifidus are very small muscles. They're very close into the spine, and they only span 1 to 2 vertebral levels. And I'm making a point of saying they're in close, and their role, they cannot move the spine because they're in so close. Their role is just to elongate or open up a few vertebral levels, so increase the disc space. So again, the core, those are the core muscles. And the reason to explain that they're very close in is because their role is to provide stability to the spine and skeleton, as well as to control changes in intra-abdominal pressure. So they are muscles that are called, I said they're postural. They don't have much leverage. They're very close in, so they can't move us. So to strengthen them by movement is not even a concept that can really be even is not a real concept. So these muscles, though, are what we call anticipatory. They preset before we do move. So I call them like our underwear muscles. You don't put on your underwear, and I'm talking proper underwear, not like little, like we have transverse abs would be like the waistband of the underwear, and the pelvic floor is like the gusset or the crotch part. And you don't put on your underwear in the morning and expect it to get tighter and strengthen throughout the day. It's there, it supports what it needs to, and then we can superimpose movement onto that. So I liken your clothes, when you put your clothes on, that would be like adding movement to on top of your core muscles. And your core muscles will be turned on prior to the actual movement. So if I go out of a door, my brain sees the door and I lift my arm to push the door, and before I lifted my arm, my core muscles have preset in anticipation of movement, so that when I push that door, I don't collapse because I don't have any stability. And the same thing goes for my intra-abdominal pressure. I go to push that door, and my core underwear muscles are ready, and then I can superimpose movement, and there should not be a huge deformation or increase in intra-abdominal pressure just from pushing the door. But where you can get an idea of maybe where that core isn't quite set, and it sets in a certain order. They have that from studies. It presets by milliseconds, but the pelvic floor muscles are generally the first that should turn on. There is a sort of a correct order that they should come in, and that is on the left, where the pelvic floor and the deep transverse abdominals come in, and then the diaphragm is free to keep moving, but generally with a heavier load, exhalation to let the pressure regulate, and the multifidus will stabilize the spine. So that is sort of the correct action that should happen. But if you go to the door and it's heavy oak instead of plywood, and your brain thought it was plywood, and you go to push it, and whoa, it's heavier than I thought, your body has to adjust, and that was sort of the pre-activation didn't quite meet the load that it thought it was. So then you will kind of, oh, I have to put a little more pressure than I thought, and depending which strategy I'll go into, but hopefully it activates in the proper strategy, and you can add a little more pressure without having a big alteration in that intra-abdominal pressure. This is one of the models, again, using the core as a soda pop can analogy, and a soda pop can is a container under pressure. It has a top, a bottom, and the cylindrical sides, and it's very thin aluminum, right? But when it's under pressure and it's closed, if you squeeze that can in any direction, it's very difficult to deform it, right? It's a pretty stable, the contents stay under pressure, and that can does not deform. But if I poke even a small hole, or I open the top of the can, or I poke a hole in the side or the bottom, then it becomes very easy for external pressure to alter that canister, and the pressure is going to go somewhere. And in terms of the patients we see, we are dealing with people who might have the pressure that is not well controlled, ending up down on the pelvic floor. So when these women come and they say, I want a flat stomach, and I need to get my tummy stronger and my core stronger, and they want to do crunches to do that. Well, again, we try and educate them, and we have an education class, that the core is not even something that you strengthen. What you need to be able to do is maintain your core while you superimpose movement. But if you have a woman who's come in and her complaints are prolapse and stress urinary incontinence, and she wants to do crunches, I would, well, if she insists, I might say, maybe we can try something else, or I will assess how she's doing it, because it's not everyone that crunches are bad, it's how you do it. But the crunches will take, the rectus goes from your lower costal cartilage and your sternum down to the pubic bone. And it is a movement muscle with a lot of leverage, so it is going to sort of bring the front of the abdominal wall shorter, and so the chance is, where's that pressure going to go? And some women may be able to have a pattern where they activate properly, but a lot of our patients, if you watch them do a crunch, what they will do is they will crunch down at the top. They will have a pooching or a tenting abdominal wall, lower abdominal wall, and if you're examining them, and I have, because just to show them, you can sometimes see their prolapse come down, right? So then you're like, you know, this is what's happening inside, but she thinks she's helping herself get a flat tummy. And again, if you think of the core as a canister, if you're compressing sort of the top and front, and you're bulging the bottom, you're sometimes going to reinforce that little pooch at the bottom, and then their goal is, I want a flat tummy, and I also want, I don't want to have hunched posture. And I said, well, you just went and did 100 reps of shortening the rectus. So again, I don't want to say that crunches are across the board bad exercise, but pair it with, I would examine the patient, or is there something else we can do to achieve your goal of a flat, if that's your goal, is flat tummy and continence, to become continent. I might not choose this as my number one exercise. So what I usually do is, and again, principles, these are mine made up, so they're not principles written in stone or anything, but what I want women to do is check in, top, bottom, front, and back of the core. And I should have number one actually be breathing. Your diaphragm needs to be free. As soon as you have locked that diaphragm, basically that pressure is going to go somewhere. And we know from studies, one of the studies, they're trying to do an intra-abdominal pressure, and the highest pressure on the pelvic floor, vaginal pressure sensor that they were using, was from Valsalva. So you want women avoiding Valsalva if possible. So if they're in Pilates and they're told to do hundreds, if you know what those are, you know, both legs are up and I say, check. Can you breathe when you do those? Because if you're like this, if you've locked your glottis and your diaphragm's now locked, you're not doing yourself any favors. You think you feel the burn on the outside because those muscles will, they're movement muscles, they fatigue, so they feel like they're doing something, but you're making a hard shell around a soft core, like you're just causing intra-abdominal pressure. So I say, check in, are you breathing? How's your abdominal wall? I don't want them pulling it in because that will involve them bracing usually some of their obliques, but what I want them to do is notice if it's tenting upwards. And even you can do that even just if you sit up in your chair and just lean back, and then you start to feel when you lose that stability is when the abdominal wall starts to tent upwards. So I have them watch, okay, don't lose that nice flat lower abdomen. And then I just say, can you maintain your length? Basically have that diaphragm off the pelvic floor. If they're coming together, pressure's got to go somewhere. So can you keep your diaphragm up off your pelvic floor? And then, what's the fourth one? Long spine, flat belly, and their pelvic floor, right? And again, that's a hard one to tell because, yes, okay, if you're having a frank symptom like you just leaked, there you go. But if you're in a class and you're not necessarily leaking or something, but back to what Kristen was saying, part of the rehabilitation is, do you even know what the heck is happening in your pelvic floor, where it is it bulging, is it hypertonic? So just checking in, like when you're slouched over, does it feel more pressure down there? So having them just check in. Usually I just say, if you can check if you're breathing and watch the abdominal wall, like I don't want to make them afraid to move, but just have some key things to watch for and hopefully avoid the scenario on the right, which is their abdominal pressure, their diaphragm's locked down, their pressure may be going abdominal wall or pelvic floor. And this goes for, we're talking about women because we see our population is pelvic floor, but this research on the core came out of low back pain research. So someone else, their pressure will they'll present with a disc bulge, or someone else now, they've even taken this research and they link it with GERD, so reflux. Pressure will go somewhere. But we're seeing the women where the pressure has gone downwards, so people say to me, well, women get prolapses. Can men get prolapse? Well, they don't have the vaginal opening, but men will herniate. They'll get hernias more frequently, and women will get prolapse from poor intra-abdominal pressure control. So we have some clinical scenarios that kind of help with this.
Just to keep you all awake.
Yeah.
Everybody stand up.
Yeah.
Okay. Sit back down.
Yeah.
Now, this time, mindfully stand up. Pay attention to what muscles you are using. How are you going about getting yourself out of the chair? So go ahead, try it again. Okay, so some of you will be fabulous and some of you will be not so good, okay? Have a seat back down again. Think about your older lady who has OA hips or OA knees, or maybe she's got a lot of degenerative changes in her lower back, she's got a lot of low back pain. What we'll often see in these people is they have no butt, they have weak quads, and they have a really weak abdominal wall. And so what they will do, I mean, you see people using their arms, right, to haul themselves out of the chair, But what these people will often do is hold their breath to generate a little bit of stability, even though that's not the ideal strategy. They're just trying to get themselves from A to B. So they'll hold their breath and they'll push their bellies out because they don't have the ability to keep that abdominal wall in flat, okay? And then they'll sort of heave themselves out of the chair. So if you think about, just feel, if you take a big breath in, hold your breath, and push your bellies out hard, what do you feel in your pelvic floor? Yeah. So these women are doing that. I mean, how many times do you go from sit to stand in a day, right? So it becomes almost like a repetitive strain injury on your pelvic floor. So they may have incontinence, but if we only address the pelvic floor, we're missing the bigger picture and we're not going to get the outcomes that we want with these people. Sort of a little bit on an aside, a squat, to be able to do a proper squat, to me is an exercise of independence as we get older. If you can't get up and down off the toilet seat by yourself, you're in trouble. So I spend a lot of time working on functional strengthening for the glutes and the quadriceps and using proper mechanics to go from A to B, okay? Teaching them not to breath hold, keep their spine long, like Meaghan was saying. And I actually teach them to try to push the floor away with their feet as they go from sit to stand to help facilitate them using their quads and their glutes instead of that abdominal bracing strategy and the Valsalva, okay? All right, so stand back up again. Excellent. Okay, let's just talk about what standing posture feels like. So if you're standing nice and tall, now everybody, when they think good posture, people come in and they're like, well, I've got to pull my shoulders back and stick my chest out. That's not neutral posture. All you're doing is over-engaging all the muscles in your back, and you're going to get sore back there, okay? So if you can think about almost, again, grounding your feet into the floor and imagining a string just pulling your head gently up towards the ceiling, and just let your shoulders fall where they may, okay? So you feel like there's space, again, in your spine, okay? And once you're there, you should be breathing diaphragmatically. So again, lots of people we see with lots of breathing dysfunction, which a whole nother talk, is very connected to the pelvic floor. They move together, okay? But breathing into your belly, your pelvic floor should be gently engaged and your abdominal wall should be gently engaged. The idea is that those core postural muscles are meeting the demand at hand. So if you're just standing there, they don't need to be super active, okay? Now, and the idea is that they would increase the reactivity if you're going to do something more challenging. So let's say you're going to lift the bag of Costco potatoes out of the trunk of your car, then they have to increase their intensity to help offset that increased load. If you do something sudden, they've got to quickly be able to do that. That anticipatory action has to kick in a lot faster, okay? So they're always sort of one step ahead of what movement is coming down the pipe. Now, while you're standing there, I want you just to bounce. So just let your knees relax, just bounce up and down. And I want you to think about, okay, my pelvic floor is a little bit engaged, my tummy's just a little bit flattened in. So as you do that, you should feel like your bladder is pretty stable. It's not sort of bouncing around. Now, we've all just had a break, so we probably all have empty bladders at this point, but imagine if you now completely relax your pelvic floor as best you can. Just think about what it would feel like if you were sitting on the toilet. So relaxing your pelvic floor. Think of your bladder being full, and now bounce again. What does that feel like? A little more precarious, hey? Okay, and relax, good. Have a seat back down again. So again, we can teach strength. I won't ask if anybody leaked, but we can teach all these specific exercises, but we still have to make sure that that patient can actually transfer all of that into function, because otherwise, who cares? It's a waste of time, right? So here's an example of the chest gripper. So if you think back to that pop can analogy, this is a really common strategy that we see in women. And you can see in the far slide She's got that abdominal crease right below her rib cage. Everybody can appreciate that, okay? So it's like the top of the canister is being squeezed. And as that happens, the pressure has to go somewhere. The only way for it to go is downwards. So she's going to get this little pooch, okay? So this is the gal again who says, I've got this tummy and I really want to get flat abs. And so, you know, I've been doing all these sit-ups, but again, you can appreciate how that's just going to make that whole pattern become even worse, okay? So again, with this lady, she may have symptoms of pelvic floor dysfunction, but we're going to get out of her pelvic floor and address her breathing. So her diaphragm sitting under the rib cage, she probably can't breathe diaphragmatically because she's completely locked down through her rib cage. She's going to have to breathe apically. So we're going to work on her thoracic spine. If she's been stuck like this for a long time, she's probably lost the ability for her thoracic spine to even move into a more extension sort of posture. We're going to address her oblique muscles, which will become habitually shortened over time if she's been like that for a long time, okay? Then we can go back and start to look at the pelvic floor. So you've got to integrate that whole canister system into one before you're going to be able to help that gal. So this is, I mean, these are common. This is kind of a Meaghan example, and I am a butt clencher. This is not me, but I do like to do this, even though I know better. We all have our issues, right? So these gals, these are your pregnant ladies, right? They'll have a sore lower back and this big tummy out the front, so they kind of lock and load their hips, and you know they have the waddle, okay? But you'll see people with sacroiliac joint dysfunction and lumbar spine dysfunction that aren't pregnant as well, quite commonly. With these guys, you'll see often a quite tight pelvic floor because they're butt clenching. They're engaging their deep hip external rotators, so those obturator internus muscles. And by default, that sort of pulls the pelvic floor along with it. So they have these short, clenched, tight pelvic floors. So yes, we can go and teach them how to lengthen and relax their pelvic floors, but why are they using that strategy in the first place? You have to step out of the pelvic floor and look at what is going on mechanically elsewhere. So we would look at stretching out their hip external rotators, working on strengthening up their the gluteal muscles so they can actually start to utilize a better strategy for moving through space.
My fitness coach said full squats will cure my pelvic floor problems. And again, I'm just kind of giving some things that women come in and say, you know, I read I don't need to do pelvic floor muscle exercises. I read that you just do deep squats, and that's going to help with my pelvic floor strengthening and my incontinence. And the logic of this comes from some of the core I was talking about. Yes, when in a proper pre-activation sequence, when you go from a deep squat and stand up, the pelvic floor should engage and the transverse, and we should exhale, and that's what should happen. But it's all based on biomechanical models, and in reality, myself included, in North America or Western cultures, most of us don't have the range of motion to get into the proper full squat that they're talking about for, so I will just show you, I'll go out of the mic, but if I do a full squat with my short hamstrings and my calf, I have to tuck my pelvis to get into that position. So now, for me to get up and say that's a good pelvic floor activation strategy for me, it's not. I can't even get into the initial starting position where I can maintain the pelvic anterior rotation in order to stand up. So here you've got women starting in a very deep squat, standing up, and repeatedly practicing likely not even a good mechanical pattern, and just reinforcing possibly again their poor activation strategy. So the other point about this is that because there are quite a few sort of schools of thought that no, you don't need to isolate your pelvic floor muscles, you don't need to train them and progress from you could do compound exercises, squats or lunges, and the most recent systematic review that has been done by Kari Bow, many people probably have heard of her, Bow and Herbert, was they looked at several general exercise programs. So they looked at abdominal exercises, the Paula method, which is an exercise program that uses other sphincters in the body to activate the pelvic floor. They looked at Pilates. And so these were randomized controlled studies looking at those exercise programs versus specific pelvic floor muscle training. And the evidence still came out from looking at those articles that in order to help with, they were looking at stress urinary incontinence symptoms, you do need to train the pelvic floor muscles specifically. You couldn't just do general exercise in those programs and then have a significant improvement in your incontinence symptoms. They also, at the time, this was 2013, they didn't have any randomized or randomized controlled trials to look at yoga, tai chi, or the breathing exercises, hypopressive or low pressure exercises, and posture. None of them had decent randomized controlled trials comparing it to pelvic floor muscle training, so they couldn't include that. There was a pilot study done, 2014, small numbers, pilot randomized controlled study looking at yoga versus pelvic floor muscle training, and they had some good outcomes. And I don't want to say we're not for general, I send a ton of people to yoga, but in this study where they were saying, can you send patients to yoga to help with stress urinary incontinence symptoms, my critique was that they picked very well-trained yoga instructors who chose 8 pelvic floor specific postures from a Hatha, a younger practice, and cued them throughout the classes, and then said, well, we had good results with improvement in stress incontinence. So I don't think if I'm sending my woman to her yoga class at the leisure center that I can guarantee that those will be such a focus. Essentially, I think they put them through a pelvic floor muscle training group class. So as far as we know now, still the best evidence is that this is the quote, "There's not yet strong evidence that alternative exercise regimens can reduce urinary leakage in women with stress urinary incontinence." So I am not opposed at all to general exercise, but just as Kristen has explained, we need to take them through those rehabilitation steps and get them to the functional, whatever they want to do. I've got equestrian women that want to ride horseback. That's quite a bit of full abduction and sort of essentially repeated gravity, like jumping. So we can get them there, but you do have to go through specific pelvic floor muscle training and then compound exercise. Because just as Dr. Birch, I was happy he put that slide up that I think it was fecal incontinence is not life-threatening. No, for most of our women, their pelvic floor dysfunction is not going to kill them, but the number one killer of women is still heart disease, and so I want women moving. However, we can get them moving in general exercise. It's just that I don't think we're helping them by saying just go do this heavy program and your pelvic floor should be kicking in. In theory, yes, but if they haven't had an exam, so again, we also advocate that they have an exam by a practitioner to see if they are activating their muscles properly, and then put them through a rehabilitation program. So yeah, I don't want it to be that we're trying to tell women not to run or not to do heavy impact exercises. No, I'm absolutely for that with the proper loading the body properly and progressively.
So, are you strong enough to lift your bladder? The real question then becomes, do you have the intact neural, muscular, ligamentous, and fascial structures that are functionally coordinated to control your intraabdominal pressure and support your bladder while you go about your activities of daily living? So simple, hey? All right, there's, I'll let you take
Well, yeah, we just put some, this is by no means an exhaustive list, but these are just some resources. If you, the Australian websites, the Australian Continence Foundation is very good. Pelvic Floor First is kind of linked off of that Australian Continence one. Diane Lee is a lot where we got our, people may be familiar with her as a physio out of Vancouver who's done a lot on the core, sacroiliac, and also diastasis recti. Her website has quite a few good articles on it, and so there's some other ones on there, and including our pelvic floor. I don't know if Grace mentioned the last link there is our online, the modules, our patient education modules are on that that website under patient education. So there's some stuff on the core in there as well. So I don't know how we are for time, if there's time for questions.
Yeah, no, I think that's absolutely appropriate. I think, like Meaghan said, we want people moving. The idea is to keep them engaged in life and being active because of all the other health benefits that come from that. And I think, you know, Tai Chi, those types of movements tend to encourage functional movement patterns where muscles are working well as a team. The only thing I would say to a patient is if you're having overt symptoms, if you're really feeling your prolapse or you're experiencing incontinence, then we need to specifically assess that to see, okay, what is happening, what strategy are you using during that exercise, and can we correct that? But if the patient is doing that program and they're not experiencing you know, significant pelvic floor dysfunction during it, absolutely, I think that's great. Yeah. I guess clinically, in my private practice, I see men, and I think, I don't mean to stereotype here, but I think they have in their mind that the concept is more is better, right? The more I tighten up, tighten, the better it's going to be, which again goes against the functionality of the muscle. Even working on the abdominals, a lot of men I see are really strong rectus abdominally, but they have no idea how to isolate their transverse abs. So with them, I would almost say to them, if this makes sense, work less hard and focus more on appreciating the mobility, feel the movement rather than the intensity of the contraction. So their focus is shifting from tighten to up and down. Does that make sense? Yeah? Yeah.
They did a great job. Thank you so much, Kristen and Meaghan.